Hi, it's Dr. Centeno, and thanks so much for joining us today. Today, I've got an interesting topic. I'm going to start a new series, and that new series is going to be taking just some of the patients I see on a day-to-day basis. Obviously, I won't include their names at all. I'll just show you the information that I got and the information I reviewed, and then go over their symptoms, what they experienced, their functional disability, what we saw on imaging, and then which types of CCI they had, what the treatment recommended is, etc. And the goal here is one of the watchers of this show had talked about the concept that many patients are interested in seeing the symptoms associated with various types of craniocervical instability. And so to that end, I thought I'd go even a little deeper than that and share some of the stuff that I look at on a day-to-day basis. Now, today, we're going to go into, in depth, a patient who had an upper cervical chiropractic manipulation. This was not in the US, this was outside the US, and ultimately had a transverse ligament injury, an alar ligament injury, and an injury at C2-3. And then we'll get into what did that patient experience? How functionally disabled were they? What does all that look like? And then how does that map back to the types of CCI they had? And then how does that map back to not only that, but what treatment was appropriate? So as usual, I'll present some slides initially. You can ask questions at any time. And that's just by commenting below and asking a question. And then you can also feel free to ask questions about this topic or really any topic at all. Okay, so let me go ahead and get to the point where I can share my screen here. And then we're going to go to today's discussion. Oops, wrong ones. So again, this is going to be a new series just based on what I've heard patients are looking for. I'm going to present some CCI cases from my day-to-day experience and from my day-to-day practice. And this one's called the head manipulation transverse alar ligament injury. Now, this is a patient who came from outside the US, and because he was coming from outside the US, we had some information, but not enough. So we had to get a digital motion x-ray here in Colorado once he was seen. So this is a patient who came in, was seen, had a DMX, then went ahead and we looked at all this information, we were able to get to a diagnosis and then a treatment plan for this patient. So let's start with his symptoms, because I've heard from some of the listeners that you're really interested in seeing what kind of symptoms might map to what kinds of CCI. So these are his big symptoms: pressure and pain in the head. That's his pain diagram off on the right. Tinnitus and stuffiness in his ears, and visual changes. Now, he had other symptoms as well. Those were just his top three. So the other symptoms were crepitus or cracking in the neck when he moved his head around, dizziness, heart palpitations, unexplained tachycardia, and brain fog. What aggravated things, what made things better? One of the things that is a common refrain in this patient, and that is with a lot of patients with transverse ligament injury, is that neck flexion tends to make things worse. Too much motion of the head and neck tends to make things worse. That's pretty common. Driving, jumping, running, all aggravated this pain in his head. Wearing a cervical collar made it better. Taking a hot shower made it better. Laying down or just decreasing head and neck movement tend to make it better as well. And the cause for all this was an aggressive head rotational chiropractic manipulation. So very different than a NUCA manipulation, very different than a gentle AO manipulation. This was the big head turn like chiropractic. Treatment, Botox was really no help. Chiropractic, acupuncture, PT, massage, no help. His functional level, he wasn't able to exercise or hold the job. And he could do some things if he modified what he did. So he wasn't completely functionally disabled, and he was able to care for himself. So this is the cervical MRI here, and let's just sort of go through here and see what we see. So he's got a couple of cervical disc bulges down here, but none of those disc bulges really correlated with his ongoing issues. So for instance, the main issues weren't numbness and tingling in the arm or hand, which would have been due to these lower cervical disc bulges. He didn't really have too much else. If you look at his ADI, which we later saw was an issue, it's not an issue here at all. He didn't really have a big grab oaks. His clivoaxial angle was normal. He did have atrophy in the upper cervical stabilizing muscles. So ultimately, when he got here and did a digital motion x-ray, we were able to see that there was opening of the ADI. So that's his ADI there. We're still getting the lines that go to the left there. Sorry about that. That has to do with the fact that I've gone to a wider screen, and I think PowerPoint doesn't quite know what to do with that. So that opening of the atlantodental interspace, as we've talked about before, is a CCI type 2A. Then he had, in addition to that, motion forward of C2 on C3, which is shown there. So that's a CCI type 3A. And then the open mouth lateral bending DMX showed problems with the C1 sliding sideways on the C2, or a type 2B CCI. So ultimately, treatment for this gentleman is going to be the PICL targeting transverse and alar ligaments, CCI type 2A and 2B. Posterior injections targeting the tender 0 through 2 facet joints, because on exam, those were a problem for him. In addition, he's got headaches in that distribution. And going after the posterior supraspinous interspinous ligaments to deal with the C2 on C3 translation inflection, or CCI type 3A. So that's all I have for him. I just wanted to present something so that people get an idea of what goes on with these patients as we see them, and how do we get to that place where we can recommend specific treatment. So let's go to some questions. Rishi, apologies for the long question, but how does Centeno-Schultz Clinic know if PICL would negatively impact other underlying health conditions the patient may have? For example, if someone has scoliosis or internal jugular vein compression, etc. In other words, does the clinic rule at all underlying health issues that the patient may have before proceeding with PICL? Is this done with a hands-on exam? My concern is the PICL could aggravate and make underlying health issues worse. So scoliosis can be a cause of problems in the upper cervical spine. So certainly nothing about treating someone's upper cervical instability would have an impact on their scoliosis. Internal jugular vein compression in the world that we're talking about would be due to instability. So that's also not going to be negatively impacted by improving stability. As far as other underlying health issues, those are going to be mostly things that would be contraindications to the procedure. So for example, someone had a recent history of cancer, for example, or if someone had had severe rheumatoid arthritis that was degenerating the upper cervical spine. Those would be the kinds of things we'd be looking for as far as health conditions that could negatively impact the procedure or if someone has untreated, for example, bleeding disorder, that could negatively impact things, or if someone is on aggressive antiplatelet therapy. So it's more of those kinds of things that we would look for, not scoliosis, because scoliosis is not something that's going to be fixed or changed in any way by treating upper cervical instability, and certainly not internal jugular vein compression, because that happens due to the instability. Resheath, patient experiences no symptomatic relief from PICL number 1 with the clinic authorized at PICL number 2. Only in certain circumstances. So if we are in a situation where we can document that the patient got some improvement with PICL number 1, that's usually where we want to be. So that would mean that the patient might have a follow-up DMX. That follow-up DMX would then show or determine whether or not we really made any progress before we went on with PICL number 2. Now, there are times that we go on to PICL number 2 simply because we've talked about the risks and benefits with the patient. We haven't been able to document anything, and the risk-benefit ratio looks favorable. So none of this is hard and fast. It's all a one-on-one determination with the patient. Susan Smith, Alar Centeno, you mentioned in a previous video that before you begin a PICL, you palpate each joint to figure out which one is symptomatic. I don't have pain as a symptom. They're all neurologic symptoms: dizziness, zapping sensation, dysautonomia. I'm concerned I won't be able to feel or verbalize when I'm feeling it, since it's all constant. Is that going to be a problem during the PICL? Does type symptoms plus imaging help you know where to go? Yeah, the only reason to palpate those individual joints one by one is to see if they need to be treated. That doesn't mean that any of them need to be treated at all. So there are certainly patients where we just treat the ligaments. We do not go after those joints because it doesn't look like the joints need to be treated. So no, it shouldn't really impact much. Regenetics, been advanced by Amber Smith. I had a serious atlas subluxation in the late 30s, but sure, it was out for decades. I noticed imbalances in my kids and had them seen by an AO. They all subluxated to a degree. How often do you see this run in families? My concern with having them adjusted is instability. I required multiple prolotherapy in order to stabilize my atlas, and I'm concerned they could have a similar instability. Any insight? Well, certainly patients who have certain things in common, like stretchy ligaments or hypermobile EDS, would be more likely to get craniocervical instability. And or things like patients with scoliosis, which would be more likely to have upper cervical rotation. So if those things are genetic, then you would see it run in families, so to speak, or at least it would be higher risk to run in families. Brian, how likely is it that an intradiscal stem cell injection makes a disc worse even when discitis doesn't develop? Pretty unlikely, but any procedure can make any patient worse. I would say in patients with central sensitization, maybe 1 in 20. In patients without central sensitization, meaning everything else is normal other than you've got a bad disc, much, much less than 1 in 100. So hopefully that helps. Rebecca, this sounds exactly like my symptoms, including visual disturbances. These all started after a 2-hour oral surgery to extract 3 teeth. I've been to several specialists with no diagnosis. Yeah, so the information I put out there today and that patient's symptoms are pretty typical craniocervical instability symptoms. One of the things that's a little bit unique to transverse ligament is that the symptoms get much, much worse with looking down. And that one tends to map more directly to transverse ligament in general. Rebecca, who do I need to see to get a proper diagnosis? Yeah, Rebecca, the only place that offers that would be our Colorado clinic. So that would be the only spot. If you're interested in scheduling an appointment, actually, I'll give you a different one here. So this is for Sherry, who's my assistant that does only scheduling. So she is, I'm just putting that in a comment so you can email her directly if you're interested. Regenex's been advanced by DB, and a patient without CCI still have their vagus nerve treated? Or can a patient without CCI still have their vagus nerve treated? At the moment, we generally don't offer that. It's possible we might, but I'd have to have pretty good information that the vagus nerve was causing that, and that's not easy to get outside of CCI. Amen. Alar Centeno, what better test, CTA or CTV? What test is best for CCI patients? We normally don't recommend either one, simply because a CT scan has a ton of radiation exposure, about 100 chest x-rays worth. And it doesn't really, knowing that, for instance, there's internal jugular vein compression doesn't really change the treatment plan very much. You're still going to treat the instability. Now, if you had to choose between those two, CT angiograms also get usually the veins, so you kind of get two for there. You see the arteries and the veins. A CT venogram generally would mostly show the veins, so probably better, just if I had to pick between those two, a CTA, where they're also looking at things like the internal jugular vein. Rish and Patel, what are the stages of healing from PRP or BMC treatment? Well, there's going to be an acute inflammatory phase. Now, that can last as short as a few days for younger patients, all the way up to a few weeks for older patients or patients with systemic inflammation. Then after that, you get into a tissue laydown phase where new tissue gets created and laid down. And then finally, and that's going to last out to really a few weeks, let's say, to a few months. And then we get into a remodeling phase where that new tissue that's laid down haphazardly aligns and becomes stronger. And that can last from, let's say, 3 months all the way up to 9 months, but in most people, 3 to 6 months. Krishna, can curve correction help post-PICL even with patients having transverse ligament laxity? According to you, have you seen good reduction ADI with one PICL? We have seen good reduction ADI with one PICL, but usually it requires somewhere between 2 to 4 treatments. And then curve correction is not something we generally recommend until someone can tolerate that. So that's not going to be for a while after a PICL treatment. So we'd start to look at 3 or 4 months after the procedure, whether or not that person was ready for curve correction. SEMO, are pains in the hands and wrists a direct result of discompressing the femoral nerves, or both, including the first rib outlet compression as well? Could be either or both, meaning that a nerve is a single cell. So that means that cell can get compressed in the neck, as you described from a disc bulge, can get compressed as it goes through the thoracic outlet in the upper extremity, can get compressed in the periphery like the carpal tunnels. So really 3 main spots that a nerve can get irritated or compressed. Amen. How common do you see tingling all over the body with CCI patients? I don't know about all over the body, but we certainly see random tingling in arms, legs, etc. in a lot of CCI patients. Now, some of those patients also have other problems. So some of them have issues with, for instance, let's say a lower cervical nerve being irritated, and that's leading to numbness in the hand, or they might also have thoracic outlet, and that's leading to numbness in the hand, or they might have a separate lumbar disc bulge, or lost their lumbar stabilizing muscles, which is separately causing numbness and tingling down a leg. Faction, did this patient had symptoms prior to receiving the relations, or was it a routine visit? Yeah, so nothing like this. He was just seeing the chiropractor more for maintenance care. No HEDS that I was able to tell. Rishi, I've had no symptoms when I bend my head forward. It's possible to have transverse ligament injury. It's always possible, but that wouldn't be the classic presentation for someone with transverse ligament injury. Russian, what's the cost of a PSEL treatment? It's running about $12,500 US right now. It's been advanced by Sherry Scott. Is proneness to CCI more frequent in very tall patients? I'm 6'1", have CCI, and my female cousin is 6'2". It's also been recently diagnosed with CCI. Well, we certainly know that tall women are more likely to get injured in car crashes, have neck injuries in car crashes, all things being equal. So it certainly makes sense that tall women are probably more likely to have all sorts of neck injuries, including CCI. Jim, I had my suboccipital tendons injected with PRP 3 weeks ago. They no longer get inflamed and are a bit more tightly attached to the skull. I've noticed that my muscles feel stronger because of this. Well, that's good, Jim. So basically, it sounds like there might have been tendinopathy or pissed off tendons. And when the tendon is pissed off, the muscle is not working well because your body is trying hard not to use that muscle to see if you can allow the tendon to heal. So it sounds like sort of stimulating some regeneration or healing within that tendon has helped the muscles turn back on, and that's good news. Brett, Dr. Centeno, I just heard in regard to consultation for probably need for PICL. I have an MRI and a cervical flexion extension, X-ray synervitude, you need DMX as well. Yeah, listen, Brett, as I always say, the more information, the better, meaning I'm never going to turn down more information that I can look at. If you're trying to get to doing the least imaging to see if you can get to a diagnosis, I think you're already there. Cervical flexion extension X-rays and MRI would be the least that we need to see. A DMX will be very helpful. It'll just increase the likelihood that we'll be able to get to a DMX or to a CCI diagnosis if one is there. Strange. Good afternoon, Dr. C. In your experience and observation, what are the early signs of healing benefiting from PICL? Is having a honeymoon phase a good indication of positive PICL outcome, or not necessarily? Yeah, it's not necessary. It's certainly helpful for us to see because I think it means we're heading in the right direction, but its absence, in my experience, doesn't mean much. Andy, have you seen any EDS patients in your career have been very minimal overhang, 1 millimeter or less on DMX? That's a hard one because we don't really image the upper cervical spines in just average EDS patients who have no CCI symptoms. All of the patients that I would see who have HEDS have, and who we do that type of imaging in, DMX, have CCI symptoms. So that's a hard one to answer based on that. Sherry, hello, Dr. Centeno, will PICL help if I have brainstem compression symptoms when I bend my neck down? You know, Charisse, I'd have to see your imaging to answer that question. So the best type of imaging for that would be an upright cervical flexion extension MRI, where we can look at what's happening with that brainstem as you look down and see what's going on with that. Susan, when CCI is a result of HEDS, is it normal for it to begin very suddenly without trauma, or do symptoms usually present slowly? No, minimal trauma in patients who have HEDS, in my experience, will cause CCI symptoms to get going. So it doesn't have to be a big trauma. It could be something silly in an HEDS patient. Amen. Can I do a CTA with head rotation for better results in case of artery or vein compression? Certainly, that's a good way to do it. It's a little bit more technically demanding, so just realize that you may struggle to find someone who can accurately do it with head rotation, just because that ups the ante when it comes to what they have to do to get the image. And for CTA or CTV, that means that they have to inject the stuff. And within a couple seconds, they're going to have to get that image with the head turn. So it's a lot to coordinate. The patient obviously has to also be able to hold their head in that position and be able to tolerate that while they do the injection of contrast. Rishi, do you have a good upright MRI clinic near your clinic that does flexion extension? We do. Jim, with combination of suboccipital tendon, PRP, and neck strengthening, I'm 75 to 80% better, only dealt with heavy head feeling. Any benefit to get nuchal ligament, C0 with C2 facet capsule treated with you? You know, Jim, a lot of that depends on your continuing functional disability, how much this impacts you, right? If you're 80% better and you're able to do almost everything you want to do, then the next step would be a hands-on physical exam. But everything always needs to be looked at as risk benefit, as I always say. So what's the risk of injecting, let's say, a 0-1 facet if that facet is symptomatic? If you're already pretty functionally capable. So all of that needs to be looked at as to whether or not additional care is required. Rishi, what do you inject to treat trigeminal neuralgia? Well, the first part would be if it's a CCI patient, stabilizing the craniocervical instability. That's usually the PICL, but not always. And then the second part would be if we're trying to directly treat trigeminal neuralgia, that would be injecting a platelet lysate, so a platelet lysate hydrodissection around that nerve. Jim, I apologize, but I wanted to ask a question from last Friday for damage to the transverse bands of the cruciform or transverse ligament. That could be treated with a PICL procedure. Yes, that's how we get at that. Okay, any other questions that are out there that I can answer? Any other questions? So today we're talking about a specific patient, imaging, history, etc., just to give you an idea of what that patient complained of and the diagnosis that we ultimately found and how we got to that diagnosis. Brett, how far out is treatment usually scheduled for consultation, assuming PICL is needed? Yeah, Brett, a lot of that depends. I would say at this point, we're at least 1 to 2 months out from the telemedicine, and could be more or less depending on the time of the year. For anyone that needs to get in sooner, we usually offer a cancellation list. And, you know, that's usually pretty reliable. I would say in any given month, we always have 1 or 2 cancellations, a patient that can't make it for this reason or that reason. So that's how we usually handle something like that. Any other questions that I can answer that anyone has out there? Other questions about this topic of chiropractic manipulation leading to an upper cervical injury or anything else? Jim, if you were to put PRP into a facet capsule, can it cause it to regenerate, tighten down? Does prolotherapy only cause ligaments to tighten? No, pretty much anything. So PRP or prolotherapy will cause ligament healing and tightening. And again, you usually get a lot more from putting the PRP into the facet joint, and you tend to get a little less from just putting the PRP into the facet capsule. It's been advanced by Harry Winston. What can we expect for weather in Colorado in September? Well, September's not that far away. Regrettably, today it's super duper hot out there. Now, hot in Colorado is a relative thing, meaning that, I don't know, let's see what temperature it is. It feels like it's in the 90s to me today, but let's see here. What they say, yeah, so 93 degrees today. That's a little unusual for this time of year. That's hot for this time of year. Normally, on average, it's in the mid 80s this time of year. Now, it's very dry here, so 93 degrees here probably feels like 85 degrees down in Florida, or maybe even 82 or 83 degrees where it's very humid, meaning it's very dry, so you don't really get that humidity causing discomfort that you get in lots of different climates. So in mid-September, let's say, mid-September, it probably should be in the low 80s. during the day. In the night, you're probably looking at in the 60s. Somewhere in there, usually there's a little crisp happening in the morning, so you're feeling a little chill in the air in the morning by mid-September. SEMO, for high-level 5-6 cervical disc bulge, roughly how many PRP injections would be required to heal all the injured ligaments? A lot would depend on what the diagnosis is. So a cervical disc bulge would rarely be the diagnosis, meaning that we would want to know what's causing the symptoms. So if all the symptoms were coming from the disc bulge, then it depends on what kind of symptoms we're talking about. So if we see radiculopathy or spinal nerve root irritation from the 5-6, then we would inject platelet lysate, usually epidural or around the nerve. Injecting the disc itself is not something we usually start with because of the added risk to the patient of doing that. Then we would inject, in all likelihood, those posterior ligaments. And so there you've got a couple different possible injections. And each of those is going to be with something different. So for instance, if the joints at 5-6 are involved, or facet joints, we would use usually high-dose platelet-rich plasma, that's leukocyte poor. To inject around the nerves, we would use a platelet lysate that's made so it's an anti-inflammatory mix. To inject the ligaments, we would use platelet lysate so it's made in a pro-inflammatory mix to cause another bite at the healing apple to tighten down those ligaments. So it gives you some idea of how all that goes. Any other questions I can answer, whether it's about this particular patient's history or anything else out there? I think we're in the back to school time. I just saw some kids go to school today for the first time. So I know if you've got kids, this is a super duper busy time of year. So I suspect that some people will be watching this after the fact, because I know this is a pretty busy time for parents right now if you've got school-age kids. Now, my kids are older, but I've got one that's still in college, so he heads off this week as well. So any other questions that I can answer out there about any topic? I'll give you another minute or two. Let's say I will be here this Friday. Not quite sure what topic we'll pursue, but I will be here this Friday. And then I'm here really for the next 3 weeks or so on Mondays and Fridays. And then we'll head out for my 6-week break. During that time, I'll be doing selected telemedicines, approximately 6 per week. And just focusing on those telemedicines with patients who are more likely to be able to help. So those are being screened so that we get those patients in first. And then everyone else on the telemedicine side will be seen once I return. Okay, guys, that looks like we are out of questions for today. You guys have a great week. Thanks for the great questions. And I will see you this Friday. Here's one question here. See if I can get this one in. Tyler, is it rare for back pain to be worse after intradiscal? It's been a year since my intradiscal procedure in the 4-5. That would be pretty rare, Tyler, to have marked increased pain for a long period of time. You know, the kind of things that I would need to know is who did the injection, how was the injection done, what was injected into the disc. All that kind of stuff would be important in trying to figure out what could have happened there, but I would say that's pretty rare. I think, as I said before, someone else had asked a similar question before. If the patient is centrally sensitized, then that could happen about 1 in 20 times. If the patient isn't centrally sensitized, then that's probably 1 in 100 or less. But always possible with any kind of minimally invasive care. Okay, guys, thanks so much. Have a great week, and I will see you on Friday. Thank you.